going to show you that. Okay, for hand range flexion, for range of motion, there is a posterior glide we are going to do, and I'm going to show you that also. But this is can be used for the range of motion as well as for the pain. My first choice for this technique will be pain, not range of motion. But will it work for the range of motion also? Yes, it will work for range of motion. Is there any further better technique for range of motion? Yes, we are going to show you that. Okay.
The next technique that we're going to cover is the tibiofibular joint technique. In this, the patient complains pain not at the knee joint line, but distal to the knee joint line on the lateral aspect, around the head of the fibula. It is a very common thing when patient says, when I climb up the stairs or I go down the stairs, I get pain in that position. So for that, what we are going to do is that please shift on that side. We first need to find where the head of the fibula will be and where you will be giving the glide. To find the head of the fibula, you need to go behind at the calf. Okay, you will find the head of the fibula at the junction of lateral 1/3 and middle 1/3 of the calf. Okay, at that point you will keep your heel and you're going to push it anteriorly in this direction, like you just saw in the video. Now take the knee into hip knee 90-90. Fine, I'm doing it from this direction so that you can see my forearm angle, how I'm pushing it. One hand will go here at the tibia, okay, and the other hand will go here at the fibula. Can you see that? Yes? Now sustain the glide, and then I will take the patient's leg into extension like this. Now, very most important thing in this is that you have to maintain the forearm angle. Now, when you're maintaining the forearm angle, you have to see that it is forming 90-degree angle with the calf. Forming a 90-degree angle with the calf, and you're pushing completely anterior. What people do is that instead of pushing at interior, they try to push it towards the medial aspect, further jamming the tibiofibular joint. Go there, can you see? Yes, and then stabilize the tibia, give the glide, ask the patient, is it comfortable? And if it is comfortable, go for extension of the knee. This particularly works when there is pain at the proximal tibiofibular joint.
Okay, so the question from this gentleman, how do you treat hand range knee flexion restriction? And this is the glide I gave to that patient who came from Assam. Posterior glide for hand range knee flexion. Anyone, by the way, having hand range knee flexion restriction? That person can be modeled. We won't charge you, don't worry. No one? Okay, then let's demonstrate on the model. And I'm showing you the video. Simultaneously, Tanmay is preparing the patient. This is what we do for treating hand range flexion using posterior glide.
So I'll be taking the belt and I'll be placing it at the foot of the patient and making a figure of 8 just like you're being seen in the video. Now, once I've achieved that, I will give the belt in the hand of the patient. Why? Because I want the patient to pull at the end range of the knee. In this, I will be giving a posterior glide to the tibia with the heel of my hand, and I will place the heel of my hand at the tibial tuberosity of the patient. And I want you to see at the forearm angle. Can you see the forearm angle here? Because here the concave part, as sir said, the treatment plane is made by the tibial plateaus, and tibial plateau are facing in this direction. Is that okay? So that is where my forearm angle will be, and I will be pushing it in a posterior direction. Now when the flexion will happen of the knee, as and when the flexion is happening, the forearm angle will also drop down because this is what is happening. Is that okay? So now, one hand goes here at the tibial tuberosity, heel of my hand. The other hand goes here at the femur, and I will be giving a posterior glide. Now, while sustaining the posterior glide, I'm going to ask the patient to please pull it with the belt and back. Take it back a little bit. हाँ, इतना लेके जाना है और पूरा पीछे लेकर आना, ठीक है? Now I'm going to go there, give the glide, go for it. Can you see how my forearm is moving along with the patient? It is going from up to low along with the tibia. Up to low along with the tibia. Very important aspect in this is the fingers which are here, they should not compress the patella. Because if you're compressing the patella, you may end up irritating the fat pad. Is it comfortable? Yes? And sustain the glide for 6 to 8 repetitions. Now what the patient is doing, he's also doing passive ROM, and at the end of the range, he's applying passive overpressure, which further helps us in increasing the range. We can go to the next.
Okay, so the next one is how to gain hand range extension of the knee joint. Even if there is a 5-degree fixed flexion deformity, remember, we are not addressing the soft tissue right now, we are addressing the joint, okay? But yes, I have seen if you do sustained one, if you do repeated one, even because of the method of because we are using the creep terminology, the creep, because of the creep, the hand range extension you achieve even if it is in the capsule or in the soft tissue. So this technique works no matter whether it is a soft tissue, of course you have to do for many number of days, okay? But if it is for the joint, even in single sitting or 2 sitting, this will achieve. But if it is a soft tissue, you may do it for few more number of days, but definitely it is pain-free way of achieving hand range knee extension. And my Masoom physios, they don't, I don't know why they don't work for hand range knee extension. They work for vastus middleis and everything, but until unless you achieve full extension at the knee joint, your patient will not respond to the treatment what you're saying, because patient is still walking with the flexion knee, okay? And if there is a flexion, the patella is not freely floating. Now it is rubbing with the fat pad and with the femoral condyle. And remember, it is the fat pad which gives pain to the patient. It is not the tibiofemoral joint, okay? It is the fat pad. It is a highly innervated joint, highly innervated structure, okay? Fat pad, synovial fold is a highly innervated structure. It is the inflammation of the fat pad that gives pain. If you offload that fat pad, immediately pain goes off. And just offloading will not help. You also need to correct the biomechanics of the knee so that fat pad do not get impinged again and again. So you're going to achieve full knee extension as a treatment of osteoarthritis. Many patients recommended for total knee replacement, but joints were good and we achieved full knee extension. Patient recovered fully. There was no surgery done. Okay. So next technique I'm going to show you is how to achieve knee extension with the hand as well as with the belt, because you might not be having this mobilization belt. So I'm going to show you both the techniques. How do you achieve and knee extension doing anterior glide? But that's not necessarily that you always do anterior glide, okay? And it is important for you to understand this thing also. In many books, it's been given that to achieve extension of the knee joint, you have to do anterior glide. To achieve knee flexion, you have to do the posterior glide. To achieve shoulder abduction, you have to do the inferior glide. Yes or no? This is what is given. And why is it so? Because this is what the biomechanics is, right? Now my question to you is, does the patient get injured in a biomechanical way? Does the patient get injured? चलो आज शनिवार है, आज गिर जाते हैं, and then oh नहीं ये तो right side है, मुझे चाहिए right side तो important है, left side में गिरते हैं, और जब गिरता है patient तो decide करता है कि anterior चाहिए या posterior चाहिए या inferior चाहिए? No, they just fall. What if the head of the humerus is already sitting inferior and you're trying to do furthermore inferior glide? You will not gain range of motion. No. What if the tibia is already sitting anterior and you're trying to do anterior glide to achieve extension? You will not gain it. So you have to find it. Which one is working? Biomechanically, yes. Majority of the time anterior will work. But in someone, if anterior is not working, do not hesitate in doing the posterior glide. Make sense? So we are showing you the techniques which majority of the time work, but not necessarily on that particular patient. On that day, this particular glide will work. You have to find out which glide is exactly working on that patient. Okay? Don't do things correctly by mistake. Do it correctly because you know how to do correctly. And maybe it is not pure anterior, maybe it is little anterior and little lateral glide. You have to find out exact angle for that particular patient. Okay, इनको बराबर में सो रही हैं बेटे, इन्हें जगा दो जरा. हाँ, thank you very much. आपको ही कह रहा हूँ मैं. हाँ, आपको गर्दन में झटका आ जाएगा, दर्द हो जाएगा. इतनी देर से, बहुत देर से सो रहे हो आप, जाग जाओ. Everyone, चलो, everyone say thanks to her and stand up. So आपकी नींद नहीं आएगी. चलो सब लोग खड़े हो जाओ जल्दी से. सब लोग बोलो थैंक यू मैडम, आपकी वजह से. बोलो मेरे पीछे पीछे, थैंक यू मैडम, आपकी वजह से हमारी गरम चेयर ठंडी हो जाएगी. क्लैप फॉर हर. क्योंकि इतनी इंपॉर्टेंट टेक्निक चल रही है, उसके बाद भी आपको बहुत बहादुरी चाहिए सोने के लिए क्लास में, नहीं कि नहीं भाड़ में जाए दुनिया, मेरी दुनिया अलग है. चलो बैठ जाओ. गुड. अगली बार मेरे को कोई क्लास में सोता मिला तो मैं उसको बेड दे दूंगा. पीछे एक बेड पड़ा हुआ है, आराम से सोना. तुम लोग चेयर पे बैठ के नहीं सोना है. सोना है तो कोई मना ही नहीं है मेरी क्लास में सोने के लिए. डिक्लेयर करो और आके यहाँ लेट जाओ बिंदास. को मैं चद्दर भी उड़ा दूंगा ऊपर से, सफेद चद्दर मुंह तक उड़ा दूंगा. पता है ना सफेद चद्दर कब उड़ाते हैं मुंह पे? क्योंकि आपके जिंदा रहने मुर्दा रहने का फर्क ही नहीं पता चलता. फर्क ही नहीं है. यू हैव डिसाइडेड ना अपना नाम आगे बढ़ाना ना माँ बाप का, और आपके बच्चे भी रोते रहेंगे कि मेरे माँ बाप गरीब थे. ओके, मेरा लैपटॉप.
So basically the patient is coming to you with complaints that they are not able to extend the knee till the last 5 or 10 degrees. In that scenario, I will place a towel under the heel of the patient, take my hand beneath the tibia at the posterior aspect and stabilize the femur at the distal point from the anterior aspect. Now what I'm going to do, I'm going to push the femur down and pull the tibia up. Don't lift your leg from there, okay? Push the tibia down and pull the femur up and then go down. Now while doing this, I'm going to sustain the glide and keep going for the range of motion for 6 to 8 repetitions for 3 sets. Is that okay? The common mistake that people end up doing is that once they go down, they leave the glide, and when they're coming back up, they again take it. So you have to maintain it throughout.
Sustain it.
Sustain it throughout. Now, the same thing can be achieved with the help of a belt as well. When instead of the hand which was here at the posterior aspect, I'm going to take the belt, place it behind the tibia below the joint line of the knee, and then take it on my shoulder. With one hand, I'm going to stabilize the femur, and the other hand is going to go at the distal end of the tibia. Now, raise my height to give the glide, and then go for the range of motion. Now, can you see how I'm moving? I'm moving from my hip, and when the knee is going down, I'm going down along with the knee. I'm not standing here and then doing a passive accessory glide. I'm sustaining the glide, going down, coming up, going down, coming up, and maintaining the angle of pull like we did for tibia when we were doing the posterior glide. Right now I'm forming a 90-degree angle with the tibia. Here also I'm forming a 90-degree angle with the tibia. Is that okay? Now this technique is usually given when the passive ROM is incomplete, when the passive ROM is not there, like a knee extension lag. Whereas in a knee extension lag, the passive ROM is complete, but the active ROM is not there. In that scenario also, I would recommend you to give that glide at least once when the patient is coming for a session. The reason is that you want to prevent hypomobility from happening, meanwhile you're getting the strength in the VMO. So in both the scenarios, it is a good idea to give the glide to the patient.
Okay, so the next technique we are going to show is what we did on this beautiful lady for her knee treatment with figure of 8 belt. and we mobilize her knee joint.
Now for this scenario, right now I'm going to ask the patient to come down on the edge of the bed. Come down, further down. Or niche aa jao. Or niche aao. Fine. And I'm going to ask the patient to grab his thigh.
Or another therapist can hold like I did for her.
Okay. Now you have two options. Either you can do it with the belt or you can do it without the belt. Now with the belt, you've already seen how I did was that I took the belt around my shoulder, twisted the belt and took my hands inside. Can you see how I made a figure of it? And how my belt is going through the knuckles. Now go there and place it just above the malleoli so that you're not giving traction to the ankle but to the tibia, but to the knee joint, sorry, okay? Now sustain that glide and lean back. Can you see how I'm leaning back? He's almost about to get up. If I pull him more, he'll be out of the bed. Okay? Now I'm going to give the traction, go for the internal rotation glide, and then go for flexion. Can you see how I am lunging forward? If you're not lunging forward, if you're just squatting down, the common mistake people do is that they lose the traction. You don't want to do this. You want to maintain it and then go down. Now, why we are using the belt and why we are not giving traction directly with my hand? Because when I'm using the belt, my grip is very comfortable. Right now, the chances are that since he is a thin patient, okay, but हमारे patient ऐसे होते नहीं हैं. हमारे patient thin होते नहीं हैं क्योंकि अगर वो thin होते हैं तो हमारे patient usually OA के लिए नहीं आते हैं. What we end up doing, we have a big calf and we end up pulling too much, further giving problem to the skin and further, grabbing the skin very hard. So when you're using the belt, it helps you in giving a very comfortable glide and you can give as much traction as you want and it will not hurt the patient. Please come on.
Okay, is there anyone who's having shoulder pain right now? Let me demonstrate one shoulder technique. Aajo. Anyone else? Who's having shoulder pain? आप बैठ जाओ बेटा इधर आ जाओ. Come there. आ जाओ जूते पहन के आ जाओ. कहाँ दर्द है आपको? क्या करने से दर्द होता है? अभी पेन कोई पर्टिकुलर मूवमेंट है जिसे करने में दर्द हो रहा है? उठा के देखो बाजू को. उठाओ लेके जाओ ऊपर. अभी पेन आया क्या? और ऊपर लेके जाओ. और नहीं आया. नीचे लाओ. पूरा नीचे लेके जाओ. नहीं साइड से नीचे लेके जाओ. अब साइड से लेके जाओ ऊपर. पेन आया तो बोलो. और ऊपर लेके जाओ. फुल रेंज. पेन है? ओके. नहीं है कोई पेन. पीछे ले जाके दिखाओ. करो. पूरा एक्सटेंशन करो. फुल एक्सटेंशन. पेन नहीं है. पीछे इंटरनल रोटेशन ले जाके दिखाओ. पेन नहीं. थैंक यू वेरी मच. गो. ही इज फाइन नाउ. Now we need a person who is having pain now. So then only you will come to know whether the glide is working or not. If someone says, no, I'm not having pain now, I get pain at that particular activity, ideally speaking, I should go with him to the field and see his biomechanics, see his way of throwing the ball and check it out and do entire assessment and accordingly do it. Right now what I'm showing, if any particular movement giving you pain, please come. If any particular movement giving you pain, then only I'll come to know whether my glide is working or not. If there is no pain, how will I check whether my glide is working or not? For that, I need to do very detailed examination and then plan out my treatment accordingly. So, sorry, you were not the right candidate to demonstrate this technique. क्या करने में दर्द होता है आपको? कर करके दिखाओ. This is giving you pain? How much pain? Okay, उठाओ सीधा बाजू को. लेके जाओ ऊपर. ऊपर 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 ऊपर. Okay, range of motion भी restricted है देखो. ऐसे घूम जाओ. Can you see? Range of motion is also restricted. ये पूरा इधर और ये not allowing me. Fine. Side से दिखा दो एक बार ऐसे करके, so they can see the difference. ऐसे खड़े जाओ. हाँ. चलो दोनों बाजू फ्लेक्शन में लेके जाओ. फुल जहाँ दर्द शुरू हो वहाँ रुक जाना। ओके, पेन आ रहा है इसमें? ओके, नीचे ले जाओ, एब्डक्शन करके दिखाओ। एब्डक्शन में ही पेन, ऐसे नहीं, ऐसे कभी भी नहीं करना है, हमेशा ऐसे करना है। यू डोंट वांट टू इनवाइट इम्पिंजमेंट। नीचे लाओ, नीचे, जीरो से शुरू करना है। जब पेन शुरू हो तब रुक जाना है। सो आई नो वेयर द P1 इज। ओके, पेन आया, ओके, ऊपर लेके जाओ, फुल 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 90 डिग्री पे, यू गॉट द पेन। कम ऑन, इससे ऊपर नहीं जा रहा? ओके, चलो आ जाओ, ट्राई करते हैं। सर ने मेरी फीस बता दी थी तुमको। अगर ठीक किया तभी, नहीं ठीक किया तो फीस नहीं लेते फिर। यू रेडी? Okay, so what I'm going to do is I'm going to stabilize the scapula from behind and going to give the posterior lateral glide to the glenohumeral joint, because this is what the treatment plane is, and Dr. Tanmay will do the movement passively. And you must be wondering, sir, को तो मालूम है पेट नहीं होना चाहिए. Now you'll realize मेरा पेट क्यों है. So this will help me in stabilizing the patient. Okay, every manual therapist have to have it, so the stabilization is very comfortable for the patient. Okay, you may hear some gudu gudu sound, that is fine, because I had a good breakfast, that's why. चलो, आपको कुछ नहीं करना है, just be relaxed.
Just be relaxed. Relax.
Three therapist technique दिखाते हैं. He's not relaxed. I'll show you three therapist technique because we want to go more aggressive. Can you come here and stabilize the scapula? So the one which I was stabilizing with my hand, now he's the one who is pushing it very strongly. Okay, patient मेरा नीचे नहीं गिरना चाहिए. Fine. We are still doing the same thing. Just be relaxed, beta. Okay. Yeah.
Relax.
Was it painful? No. Okay. Keep doing that. Sir, सीधा रखो. मेरी तरफ क्यों घुमा रहे हो? I'm not your girlfriend.
आपके पेट पे रेस्ट करो.
मेरे पेट पे रेस्ट करने जा रहे.
Is it comfortable?
So he's doing a little bit of traction and doing it passively while I'm maintaining my posterior lateral glide, and this handsome boy is stabilizing his scapula. Okay, just relax now. I'm not relieving my glide till he come back to the neutral position. Check your range now, please stand up. Check the range again. No, abduction. Abduction was giving you 90-degree pain. Pain? Okay, नीचे लाओ, नीचे लाओ, लेके जाओ ऊपर. जैसे 90 पे शुरू हुआ था, बताना पेन है क्या? पेन है? पहले से कम है. ओके, कितना कम है? 50% कम है. ओके, keep going. Keep going, keep going, keep going, keep going, keep going, keep going. Look at the range now.
Go for the end range.
Go for the
पूरा
end
लास्ट
range.
तक जाओ और वहीं रुको.
Keep going, keep going, keep going, keep going. How is the pain? हाँ? अभी पेन नहीं है, आवाज नहीं आई, जोर से बोल थोड़ा सा.
अभी दर्द नहीं है.
एक बार फिर से उठा. चलो, पूरा ऊपर. Did you see the difference? बैठ जाओ. That means it is working. So that was the assessment actually. Okay, if it is working, we do 2 more times. Stabilize. So I'm going, he's stabilizing the scapula. I'm giving the glide now, posterior lateral glide, and then, check your pain now. Do the movement. No pain. Flexion करो. No pain. External rotation में पेन आ रहा था. इसमें थोड़ा सा है, तो इतने में इतना ही मिलता है.
Better.
So we'll do the lateral rotation now. You're going to do the appending movement, okay? So just stabilize karo. Okay, now let me tell you, I could have done it alone, but I'm taking his help to stabilize the scapula. Actually, you should do it alone. I'm not doing it alone. There is a reason, which many of you do not know. I unfortunately got AVN of my hip, so I'm not supposed to do the loading. And just 3 weeks back, I fractured my lateral malleus. यहाँ आने से पहले पीओपी कास्ट काट के मैं यहाँ आ गया कि मेरे को आना है. So I'm not doing all the loading. That's why I'm taking their help and moving with the fracture and AVN. So now I'm trying to treat his offending movement. Okay. So just be relaxed now. Okay. Don't do anything. How's it? Painful or not painful? जोर से बोलो.
Not painful.
Not painful. So I'm giving the glide and this glide is not causing any pain to him now. That means my glide is working on him. Okay, just be relaxed now. Relax. Chalo. Just shake your hand. So fine. ऐसे नहीं करना होता है, ऐसे करना होता है. Give me your hand. Just be relaxed now. Chalo. Check it now. No pain? All movements are free? Do the flexion again. Take it down. Do the abduction again. Take it down. Thank you very much. Clap for him. जब पेशेंट आपका ऐसे ठीक होके जाएगा और पेशेंट भेजेगा या नहीं भेजेगा? अब इस पेशेंट से मेरे को कितना चार्ज करना चाहिए अगर मैं प्रैक्टिस में हूं तो? ये वाला पेन फिजियोथेरेपी में आपने 500 रुपए रोज लिए, 10 दिन बुलाया, कितना हो गया? 5000. पेशेंट ने तेल भी लगाया, टाइम भी लगाया, सफरिंग भी हुई. एक सीटिंग में अगर मैंने ठीक करके भेजा, उसका तेल बचा, पानी बचा, सफरिंग बची, आने जाने का टाइम बचा, एंड आई डेफिनेटली डिजर्व 5000 रुपीज नाउ फॉर दिस विजिट. ही इज स्टिल इकोनॉमिकली, ही इज स्टिल इन अ बेटर पोजिशन बिकॉज अब वो काम धंधे पे जा पाएगा अपने. एंड आई एम ऑल्सो इन अ बेटर इकोनॉमिकल पोजिशन, राइट? दिस इज वॉट द इकोनॉमिक्स वर्क. हाँ जी, क्लैप फॉर हिम. थैंक यू वेरी मच. डार्लिंग, वो जो सुबह से थ्योरी पढ़ाई है वो यही था. तो हमने स्कैपुला को लॉक नहीं किया था. वी अलाउड स्कैपुला टू गो विद द पेशेंट. इट वाज स्टेबलाइज्ड विद रिलेशन टू द हेड ऑफ द ह्यूमरस ओनली. वी डिड नॉट ब्लॉक द मूवमेंट ऑफ द स्कैपुला. अगर मैंने स्कैपुला को स्टेबलाइज नहीं किया तो ये स्कैपुलो थोरेसिक मूवमेंट आ रही है. मेरे को चाहिए ग्लिनो ह्यूमरल, तो मैंने स्कैपुला को स्टेबलाइज किया और ह्यूमरस को मैंने पुश किया. तो पोजिशनल फॉल्ट में ग्लिनो ह्यूमरल जॉइंट की करेक्ट कर रहा हूं, बट आई एम नॉट ब्लॉकिंग मूवमेंट ऑफ द स्कैपुला. सो स्कैपुला वाज अलाउड टू रोटेट. इट विल रोटेट. आप सर भी पटक लो, लटक भी जाओ तो रोटेट करेगा ही करेगा. सो वी आर नॉट ब्लॉकिंग दैट. ओके. Now, because you have asked this question, so I must answer. There is already a published study by Jenny McConnell, okay, and she has found those who are having shoulder pain, their head of the humerus is sitting little anteriorly. Now, if the head of the humerus is sitting little anteriorly in the glenoid fossa, the biomechanics of the rotators get altered. Okay, certain rotators are working overly and certain are not working because of the physiologically insufficient position. So those who are working more, you get the supraspinatus tendinitis. When I push it back, all four are in optimal length and they all start working. And then all the other theories I have explained already. Correcting the positional fault, intense stimulation, okay, all those things are working. Is it answer to your question? Thank you very much. So how did we do this? Now let me demonstrate. So earlier it was a single therapist technique because we were asking patient to move it actively. Now we do it passively only. We don't do it actively. Because of the compressive forces, you lose the glide. That we have already discussed.
So what I'm going to do, I'm going to take my palm and place it at the head of the humerus. In the video, you can see where we are placing the hand. I'm taking my hand where I'm taking it at the lateral end, I'm putting my heel just medial to the head of the humerus so that my palm goes here. Now I want everyone to do this. Can you find the lateral concavity of the clavicle? Can you find the lateral concavity of the clavicle? Go down, you will find a dent. Can you go down and find a dent just medial to the shoulder? That is the point where you will be keeping the heel of your hand so that the palm goes at the head of the humerus. I am here now. Can you see how my forearm angle is? And then I'm going to take my another hand and stabilize the scapula. I'm stabilizing the scapula so that, thoda sa aage hoke baitho please. I'm stabilizing the scapula so that this movement does not happen. That is why I'm stabilizing the scapula. I am not holding the scapula as Sir said, okay? Now, push the scapula towards the thoracic wall and push the humerus posterolaterally. Can you see this? Okay, can you please zoom on my hand? Fine. Can you see this? I'm pushing the scapula front and the head of the humerus in a posterolateral direction. Now I will maintain the glide, and usually we do it for passively, but because for demonstration I'm just doing a single therapist technique. I'm going to ask the patient to take the hand into flexion. Side में रखेंगे हाथ को, palm facing upward, and just go for flexion of the shoulder, not the elbow. Pura, full range, come on, go for it. Now can you see how I am stabilizing the scapula and also moving my hand along with the humerus? And just doing simple pronation and supination to maintain my glide, and also I am moving along with the scapula. Movement is very minimal, but I am moving. And similarly go for abduction, palm facing upwards.
Whichever is the offending movement, you ask patient to do that movement.
Pura
Okay?
leke jo. That's it, and come back. Is that okay for everyone? Now, what many times people do that instead of taking their head behind the head, they go here. This is wrong. Make sure that you're here, behind the neck of the patient. That's it, we can go next technique.
Okay, and just two more techniques, and then if time permit, we'll show more. But two more techniques I must show you because I promised you. Next one is the how to gain and range internal rotation and how to increase the SLR. Meanwhile, anyone who's having radiating pain or tight hamstring, select yourself. So we'll call you as a model if you want to be. Okay, tight hamstring or the or reduced SLR because of the pain in the back of the thigh. You have? Or anything? Okay. So before that, I'm just be ready. We'll call you here. Maybe you can come here. Before that, I'm showing you how to gain and range internal rotation of the shoulder. By the way, I have muted these videos so Tanmay can speak. Otherwise, these videos has the audio also. I have purposely muted so that video का और तन्मय का audio आपस में match ना करें, mix ना करें.
So this technique is very well useful when the patient complains of inability to get this last range. In this, I want you to make sure the one thing that this is not internal rotation. This is just flexion and abduction at the shoulder. This is internal rotation. Okay, ensuring that the shoulder goes into 0 degree of abduction and then going for elbow flexion, that is internal rotation. Many times the problem happens is that you keep gaining this range. And then when the patient actually says, Ki, Doctor Sahab, I'm not feeling better, but you clinically think that you've done something. This is the range that you want to achieve. Okay, now for that what I'm going to do, I'm going to take a belt, either give it in his hand to hold it, or I can wrap it around his wrist, whatever you prefer. Now give this belt to the other hand, pakdo isko idhar, so that he can abduct his shoulder up and then pull it up. Pull it, leke jao pura upar, like this. Is that okay for everyone? This is what the range of motion I want the patient to do. Come back. Now how do we give the glide? You will take a towel because your hand will go deep inside the axilla. So you need to make sure that your hands do not get wet. You will take your hand such a way that your fingers are stabilizing the scapula and your thumb is coming out from the front. Here. Can you see this? Can you see how my hands are placed? And my first web space is going inside the axilla of the patient, and the other hand will be going at the forearm just below the cubital fossa. At the forearm just below the cubital fossa. Now the stabilization is going to happen in this direction towards his ear. And I'm going to push the humerus down completely inferiorly along the long axis of the humerus. Go there, stabilize it, keep your hand here, bend your elbow a little bit. And then push it down. Can you see? Can you see what I'm doing? I'm taking the scapula up and pushing the cubital fossa down. Both to be done simultaneously with equal forces. In case your force is not equal, the stabilizer and the mobilizer force is not equal, what will happen? Either the patient will bend towards you or the patient will go away from you. Now, patient needs to remain static. Can you see that? And now I'll ask the patient, please pull the belt up. And let me know as soon as it's comfortable or not, and come back again and come back. Now, at the end of the range, you know what I will do? Take it up, hold it there. With the help of my tummy, I will apply an adduction. Now, what is that adduction doing? It is acting as a passive overpressure for the patient. So, when he goes down, take it down, come up, and then apply adduction. Go down, come up, apply adduction. Okay? Now, in case you feel that the patient is not able to do an effective pull, you can have another therapist who does that for you. You can also go for a hold relax along with it. In order, sometimes, you know, the patient is very apprehensive in taking it up. So, initially what I do many times is that I give the glide, ask one of my therapists to perform a hold relax only at that point. We do not go for the range of motion. We just do a hold relax at that point, relax the patient, make the patient calm, and then we go for the range of motion. That helps a lot as well in achieving the end range internal rotation. Sit, we can go to the next thing.
Okay, so can I have you here?
Thank you. Please have a seat.
जीन्स पहनी है क्या? जीन्स के साथ करने में दिक्कत आएगी. कोई और है पेशेंट? आ जाओ. You have tight hamstring or radiating pain? Okay, please come. With jeans it is difficult because we will not be able to achieve that end range. फिर भी हम जितना स्ट्रेच करेंगे आप उतना ही, आपकी जीन्स नहीं करेगी. अभी आप देखना. आपकी जीन्स उतना सपोर्ट नहीं करेगी. और बाई चांस धागा चाइना का निकला तो दिक्कत हो जाएगी. बहुत बार वर्कशॉप में बच्चे आ जाते हैं टाइट कपड़े पहन के और हम एडक्टर स्ट्रेचिंग कराते हैं तो फिर वो बाद में रोते हुए घर जाते हैं.
Okay, she has a question. She said that when I said that, you know, you give pressure with the help of a tummy, how will a female physio do it? A female physio will put a pillow in front of them, make it their own tummy, and then push it with the help of the pillow. That is what we usually do. Okay?
और अगर फीमेल फिजियो ने टमी के आगे पिलो नहीं लगाया तो वो पेशेंट कभी भी ठीक होगा ही नहीं, वो आता ही रहेगा पेशेंट. और आपकी ओपीडी बहुत बढ़ जाएगी. अगले दिन अपने दोस्त को भी लेके आएगा शोल्डर पेन के साथ में वो. This is the technique I'm going to show you, okay?
Okay, so she's saying that she gets radiating pain when her leg reaches up here, and to that she's saying that she's a classical dancer. So in this scenario, you know, I will do two things. First, I need to rule out whether it is the muscle or whether it is the nerve. Many times people complain that, you know, that this is sciatica and SLR is positive. In this scenario, what I will do, I'll ask her, I will hold it here with my hand, and then ask her to take her neck into neck flexion. लेके जाइए ऊपर. Now, then I'll ask the patient, did the pain increase or decrease? Did the pain increase or decrease or remained same? It remains same mostly, which gives me an indication that it may not be neural involvement, but more to do with the muscle that the patient is complaining of. When the neck flexion happens and there is an increase or decrease, the chances are that it is more to do with the neural involvement because I am tensioning the nerve from both the ends. Okay, so doing that assessment, why is that important? Because it allows me to know how aggressive I can go when I'm doing this technique and how much precaution I need to take when I'm treating the patient. Okay, so what I'm going to do, I'm going to raise the height of the bed a bit more.
Anyone else, because she's already having
Can
good
check
range
on
of
this
motion,
leg.
and she's probably trying to
Can we
become a
check on this leg?
superwoman. So, can you
okay.
just show me what is the range?
Please come down.
Stand up. Stand up.
It's okay, it's okay, it's okay.
Bend forward without bending the knee. Show me the range. Bend forward. Stay there. Okay. Madam, can you show me? Okay, you come please. We got a better model. No, करके देखो. हाँ. Pain के लिए तो देख लो ना. If she is having pain, at least range और नहीं बढ़ानी है हमें. But जिस range में pain है उस range का अगर हम pain कम कर दें तो that will be good.
Range as such is not
So,
an issue.
we have a
More to
bad-
do with the end range. She's complaining pain. Okay.
Pain right now as I'm sleeping also. It's radiating down.
Fine. So she's saying that when she's sleeping down also she's having pain right now. So for that I'm going to do the technique
That
on her.
means we are going to treat her
Lumbar spine.
spine. Not just that area, okay? In supine lying. Go for, she's not the case now. Send her back. So we will do the flexion based exercise for her and do the posterior tilt, pelvic ka posterior tilt wala hum manual therapy karayenge and she will respond with that. Okay, I'm sorry you are not the right candidate for this technique. You are a candidate for manual therapy but not the one which we are demonstrating. Thank you very much. Clap for her. Aajo.
Please. I'll ask her to raise the leg without bending the knee. As soon as you feel a stretch, stop. Fine. So this is the range that without bending the knee. ऊपर उठाओ.
जहाँ पेन या स्ट्रेच है वहाँ रुक जाओ.
Fine. So what we are going to do, we are going to measure it.
Can I pull it a little bit?
Now, this is the range where she is complaining of pain. Is that okay? This is how much she's right now complaining of pain. Now I'm going to take the belt, keep it secure, and then ask her to take it down. Fine. Come towards the edge of the
We
belt.
measure SLR
Your
by
name?
using the measuring tape. Rather than doing it in degree, we do it in inches. So it is much easier, much more relevant also. Because आपने गोनियोमीटर का फलक्रम
hold
कहाँ
the
रखा उससे आपका range of motion बहुत change हो जाता है. So this one we do it with the measuring tape.
Fine. During this, the patient may feel, that they will fall. They may feel it, but they don't. Okay, you need to make sure that you are well stabilized and your position is such that the patient does not feel that.
बेटा अभी तक तन्मय ने सिर्फ 313 पेशेंट गिराया नीचे.
सर 313 नहीं थे वो 314 थे 300 कोई नहीं. So now what I'm going to do, I'm going to start, the starting position for this is that this needs to be in hip knee 90-90. Sometimes when the patient is complaining of sciatica, they're not able to take it in this position. So what do? We go for a hold relax. I ask the patient, okay, push my hand down, knee extension mein jaake. Okay, push it and relax. Push it and relax. So with the help of the hold relax, you can achieve this hip knee 90-90. Now, I want you to see one thing, that I have increased the flexion at the hip, but I have also increased the flexion at the knee, ensuring that the length of the sciatic nerve remains same. So throughout the range, I'm not trying to stretch the nerve. I'm trying to make sure that the nerve remains at the optimal length so that the tensioning of the nerve does not happen. Now, what I'm going to do, I'm going to take my shoulder inside the popliteal fossa of the patient and my both
तन्मय take her permission to fold it up to the
Is it
thigh,
okay?
so that they can, otherwise
Is
it's
it
coming
okay?
in your way. Yeah.
Yeah. Here, can you see that? Relax your knee. Now, the patient is relaxing her knee on my shoulder. इसको extend नहीं करना है और बिल्कुल ढीला छोड़ देना है. ठीक है? And then I'm going to take both of my first web spaces inside the popliteal fossa of the patient and then give the traction. Can you see the traction that I'm giving? Yes? Now maintain the traction and take the knee towards the shoulder of the patient. Is it comfortable? Is it okay? Stretch ho raha hai. Now if the patient complains of stretch, you can go either for abduction, you can either go for external rotation, or you can go for a hold relax, or you can go for more traction. Any of the four can be done. Okay, now push me back.
On a real patient, probably you don't want to go that much
And
aggressive.
relax.
You will stop wherever patient
me
wants you
back.
to stop.
And
But
relax.
because
How's
she's
it now?
not a genuine patient or
Stretch
a
hai,
real
abhi?
patient, just the tight hamstring, so
Zyada
we are
hai,
going
abhi?
very aggressive. Now you know why we didn't call you with the jeans.
Push me back. and relax. दूसरा पैर अगर ऊपर उठता है उठने देना.
The
कुछ
shoulder
नहीं
is
होगा.
almost
अभी
close to the knee
comfortable है?
joint. Sorry, knee joint is close to the shoulder now.
अभी come on. Okay, now push me back. Come on, push it, push it, push it, push it, push it, and relax. Push it,
Patient looks like a helicopter,
relax.
but that's fine. She will not fly.
push it. Come on, push it, push it, push it, push it, push it. Come on, relax. Push it and relax. Can you see that her other leg is stabilized by my hip and she will not fall?
He's blocking her
Push me and relax.
other leg
Push me
from his back
and relax. Don't
and the
fall, don't
pelvis.
fall. Push me and relax. Sir ने झूठ कहा था, नहीं गिराया मैंने. Push me and relax. Come on, push it and relax. Now,
Are you comfortable, beta?
now maintaining the traction, I will come back to the starting position. See the
Was
leg
it painful or you were comfortable?
She was comfortable throughout.
Say comfortable. Good.
Okay. Neha, relax.
नहीं नहीं उसको फोल्ड करो ताकि वरना बहुत दिखेगा नहीं. ट्राउजर को फोल्ड ही रखो.
Fine.
So this was the range.
This was the range. Now, Neha, take it into. Come on. Can you see that the amount of range that we've achieved? And this was the technique that we did in the patient where we took 120 seconds to increase the SLR.
Okay. So, sir, एक और technique, अवगटे technique. हाँ, तापर एक sorry. Okay. Anyone having tight adductors?
Thank you.
Please come.
Please clap for Neha, everyone. Thank you.
मैं QR कोड बाद में भेजता हूँ आपको. हाँ? Thank you, बेटा. God bless you. दूसरे पैर में टाइट रह गया होगा, so we'll teach you the self treatment. It's there on my YouTube video. ये सारी videos with audio मेरे YouTube पर और Instagram पर है. You can go and see the self treatment there. यहाँ पर मैंने audio mute कर दिया उसका, है ना? आ जाओ. Come here.
Please empty your pockets.
Turn around. Trouser ऊपर जाएगा ना?
थाई तक.
Because हम तो ऐसे खींचेंगे, पैंट नीचे आ गई तो दिक्कत हो जाएगी. पैंट आ जाएगा नीचे, तो लेकिन फिर एडेक्टर में धागे ने साथ छोड़ दिया तो रुक जा, हाथ पकड़ मेरे. चलो स्ट्रेच करो. हाँ, जब पेन आए तो रुक जाना. बस तन में मेजर करो. Okay, so this is the range he is having, and we are putting the. We don't have the measuring tape right now, so we are using the belt.
Can you help? Excuse me. क्या उधर से पकड़ोगे प्लीज उसे?
आप मत करो,
आप नहीं
मत-
पकड़ो सर, आप नहीं
गिर
पकड़ो.
जाओगे.
उधर से पकड़ो, heel से मैच कर दो. Fine. Can you see that this is the range that we have available for him? इधर दिखाइए प्लीज. नहीं जा रहा, कोई नहीं. Leave it.
कैमरे को और थोड़ा सा नीचे कर लो.
Okay, so this is the range that we have available right now.
आ जाओ.
You need another belt, correct?
We'll need one more belt to mobilize him, and one more therapist for sure. Let go. ट्राउजर को जितना ऊपर कर सकते हो ज्यादा से ज्यादा उतना ऊपर कर लो. बेल्ट चाहिए एक और, ये रही ना. So what we are going to do is नहीं, उसका मेरे पास वीडियो नहीं है. So we're going to make figure of 8 there and then put it there. Actually it should be on the skin, not on trouser at all, because you want to have that neurophysiological effect for sure. And then Tanmay is showing you from his side, so you'll be able to understand what he's doing.
And I will repeat the same thing. Take it here. Now I'll ask the patient to take his
Just be
abduct
relaxed.
abduct the legs,
Bend your knee.
bend your knees.
Both knees, yeah. Be
Now, once
relaxed.
he bends the knees, we have to make sure, that we are in the center of the femur. We are not next to the femur. Femur ka jo bone line hai, it should come through the center of our body. Now, me and sir both will give traction.
नहीं कुछ नहीं
कुछ नहीं
होगा.
होगा. And then we both will go
You
for
be relaxed.
abduction.
इसका पैंट अब रिस्ट्रिक्ट कर रहा है हमको फर्दर रेंज में जाने के लिए. That's why it cannot be done. You are coming at your own risk. We are going to achieve our target. पब्लिक देख रही है, हम तो नहीं फेल होंगे. दर्जी फेल हो गया तो हमारी गलती नहीं.
धागा चाइना का ही है सर. खींचे and we'll go for abduction. In case he complains pain, we'll go for external rotation. How is it now? Abhi?
Okay, sit down now. Please sit
बैठ
down.
जाओ.
And if someone is having weak abs, you give support.
हाथ आगे रखिए.
Just be relaxed. दोनों हाथ रखो आगे.
Go for
रखो आगे,
push-ups.
इतना आगे नहीं, पास में रखो.
हाँ, बस अब
Now
push-up.
use your arm muscles and do the push-ups.
Push-up.
नहीं नहीं उठना नहीं है, आगे चेस्ट को नीचे लेके जाओ हाथों की तरफ.
सर
Elbow
अपने
bend करो.
नाक को बेड से टच करो.
हाँ.
एक.
Everyone, come on, cheer him. 1, 2. Come on, 3. Everyone, come on यार, कितनी मेहनत कर रहे हैं तुम्हारे लिए.
4.
5, 6, 7, 8, 9, and 10. Go back. That's it.
Lie down.
Then you release the patient. अच्छा इसलिए लेने गए थे क्योंकि उसमें मेजर करना है बेल्ट को. ओके ओके.
बेल्ट दीजिए प्लीज.
हाँ.
प्लीज गेट अप.
ये वाला.
फ्लोर की तरफ दिखाएंगे प्लीज.
हाँ इधर इधर आ जाओ. यहाँ से दिखेगा शायद.
और नीचे कैमरा.
कैमरे को इनके पंजे की तरफ ले जाओ. हाँ ये वाला.
और जूम आउट कर देंगे प्लीज.
चलो
थोड़ा आगे आइए प्लीज. आप सर आगे लेंगे ना.
आप आगे आ जाओ. यहाँ पर बस.
दैट्स
चलो.
इट. या.
अब हाथ पकड़ो मेरा जितना जा सकते हो. अगेन व्हेन यू गेट स्ट्रेच यू कम देयर. तन में रखो बेल्ट को. So that was the range before.
मैं कीजिए बस. हट जाओ आप. हट जाओ हट जाओ हट जाओ. छोड़ दो.
और जा सकते हो. थोड़ा सा और जा सकते हो. पैंट नहीं जाने दे रही. पैंट कह रही है मत जा भाई, जान दे, मान जा बात को. इतनी बहादुरी मत दिखा. So you can go furthermore. Good. Was that painful now? No. So we did this actually. In fact, we have developed this technique in Capri, and now it is taught worldwide. This is the technique we developed in Capri, and accidentally we developed this technique when I was teaching in SSG Medical College, Baroda. So one of the students was doing it wrongly, and we saw the result. Result was awesome, and we said, okay, thank you very much. You have helped us in developing the technique. And then we did a study, controlled study. Half of the asymptomatic participants, all were asymptomatic. Half of the class, we did the conventional stretching of the adductors, and half of the class, we did this one. Okay, the one which was doing conventional stretching, first thing, it was painful, and only some amount of abduction got increased. But when we did this, it was pain-free technique, plus not only the abduction got increased, also the flexion of the hip got increased, also the abduction, internal rotation, external rotation, and the hip extension. All the range of motion of shoulder of the hip joint got increased, that too in a pain-free way. This was the technique we did on the rheumatoid arthritis patient I showed you in the case. And beautiful technique. Whenever patient comes with any hip joint problem, we perform this technique and we get beautiful results with this. Thank you so much. So I think now we should end up because it's more than, we have taken time more than what was allocated. So remember one thing again, I'm showing you the same thing. My slide, please. My projector. So remember that. And on few cases, we have already shown you that medicine can change physiology, not the physics. And whatever pain relief we got here was because we corrected the physics, okay? We corrected the biomechanics. We corrected the alignment. With this, thank you. Thank you so much for your patience. And in case you have any question or answer, I'm not going to have lunch, okay? I'll be available here, so you may stay and ask your question or answer. And those who do not have question or answer, or they are feeling very hungry, या उनको बहुत जोर से प्यास लगी, अपनी प्यास बुझाने वो लोग बाहर जा सकते हैं। बाकी लोग यहाँ रुकना चाहें तो रुक सर इसके बाद कल्चरल हो रहा है ना, या अभी रुक जाओ भाई, कल्चरल है, तुम्हारे दोस्त परफॉर्म कर रहे हैं यहाँ पर, शायद कर रहे हैं सर। ओके, तो लंच होगा, तो जिसको खाली पेट में भूख लगी है वो जाके लंच कर ले, जिसको दिमाग में भूख लगी है और क्वेश्चन आंसर है पूछना चाहते हैं वो यहाँ रुक जाएं। और मे बी कि आप भी रुकना चाहते हैं, बिकॉज हो सकता है कुछ ऐसा क्वेश्चन वो पूछे जो कि आपके दिमाग में आया ही ना हो, इतने मासूम हो कि आपको क्वेश्चन भी नहीं पता। सो यू मे विश टू स्टे हेयर, बट बिफोर दैट लेट मी रिलीज द organizer and the stage, and if you have any question we'll be happy to answer that. Thank you so much. Thank you PP sir, thank you all, everyone.
I have got one question, exact one question, Dr. Deepak.
Please sir, please sir.
This adductor stretch, have you applied on spastic patients, and did you find any carryover effect?
Thank you so much sir for asking this question. We published one research article, it is published in international journal. Dr. Snehal Deshpande has the same question in one of my workshop, and she's a pediatric physio, she treats only CP. She said, can we do on CP? You have done it for MSK, but what about the CP patient? Then I had no idea whether this is going to work on CP or not. So we said, okay madam, let's take it as a project whether it is working or not. Work kiya to publish karenge, nahi work kiya to bhi publish karenge, that it is not working. And to our surprise, it works beautifully. On few of the patient we did it, but only thing we need to be careful, we have to hold of the patient when they walk. Because the effect is so good, they have a habit of walking in the same scissor gait, and they don't realize after this stretching, the spasticity goes down drastically, and one of the adult CB patient fell down, and we felt so bad. It was our mistake, we didn't realize कि patient को अंदाजा ही नहीं है कितना अच्छे से वो ठीक हो गया. So the result was comparable with the Botox and without Botox. So we got beautiful result. And not only this adductor stretching, even for the hamstring, BLR we did on CP patients, and beautiful results. These two techniques work beautifully on CP, and they were not needing any Botox. We did on few number of cases, and then this paper is already published in research article. Thank you for asking this question, really important.
Thank you very much.
Thank you. And I'm glad you are my chairperson. Basant bhai, thank you so much. We were in the same hostel. With this, thank you so much. And if you have any question, sir, allow me, I can take your questions. जिसको जाना है वो चले जाए, जिसको नहीं जाना वो क्वेश्चन आंसर ले सकता है. क्वेश्चन है तो क्वेश्चन पूछ सकते हो, related to manual therapy or not related, any question. You may ask sir, दाढ़ी सफेद है, बाल ये मुझे काले गए. Ask any question, I am here for you people, because इतनी दूर से सिर्फ आपके लिए आया. मैं किसी और के लिए नहीं आया हूँ, सर ने आपके लिए बुलाया. You can ask practice से related question, any question you can ask, not related to only this presentation, anything. I'm here for you people. Explain about? भाई ये मुझसे ज़्यादा explain पीपी सर करेंगे जाके. Orthopedics की book में देखो, Deepak Kumar is not meant for that. Please, really. I'm not here to teach you orthopedic and neurology, because your teachers are much more knowledgeable and skilled than me. I am here to teach you only manual therapy and only how to establish your practice, on only how to make more money from your existing practice. So that way. Listhesis हर किसी को पता है. आप मेरी knowledge check कर रहे हो या सच में मासूम हो? लिस्थेसिस में देखो, मैं आपको बताऊं, मैंने कल भी बोला, क्योंकि कल ये मैंने आंसर दे दिया था इसलिए मैं नहीं दे रहा हूं. लिस्थेसिस में ब्रिंजिक जी एट ऑल की स्टडी है 1995 की, नहीं हाँ 1995 की ब्रिंजिक जी एट ऑल की स्टडी. ईयर शायद मेरा गलत है, लेकिन ब्रिंजिक जी एट ऑल है, उसने स्टडी किया था, और उसमें एसिम्प्टोमेटिक लोगों में अलग अलग एज में बहुत सारे लोगों में स्पॉन्डिलोलिस्थेसिस पाया गया. दैट मीन्स कि हम में से भी बहुत लोगों का होगा, और अगर हम एमआरआई एक्सरे नहीं करा रहे हैं तो हमें पता भी नहीं है. पता चला एक्सरे एमआरआई कराया, फिर लिस्थेसिस यहाँ नहीं यहाँ हो जाता है हमारे को, है ना. और फिर थेरेपिस्ट कहता है नहीं ये वाली एक्सरसाइज करो, ये नहीं करो, कुछ नहीं है. इफ इट इज अ नॉन ट्रॉमेटिक एंड अप टू grade 1, डू व्हाट यू वांट टू डू, इग्नोर दैट. Probably this is a relevant answer to your thing rather than explaining what is spondylolisthesis, which everyone knows. Okay, then I didn't hear it properly, my mistake. Technique for spondylolisthesis, we'll go for flexion based exercise. Lion's exercise is the one. Lion's exercise is the one, going in all quadruped position and then sitting back on the feet. I didn't hear it properly, my mistake.